Hi, this is Saud Anwar, Dr. Saud Anwar. If you saw my previous video, we showed you about using one ventilator to ventilate 7 lungs. Now, there are some intricacies and important things to keep in mind. First of all, the reason we are having this conversation is because we're in the midst of a pandemic. Ideally, we know for a fact, and everybody knows this, is that one ventilator is meant for one person and one patient. So that's a pretty straightforward thing that everybody knows, and we work with that mindset. Having said that, the reality is changing a little bit, and for a clinician who is in the front line, my fear is, and that is the fear that everybody around us right now has, is that we do not have enough ventilators. And in the circumstances when we do not have enough ventilators, we have two options. Let people pass away without getting the support that they need, or try to fight the best that you can to be able to save as many people as you can. That is the principle that I work with, and that is the perspective of why I am trying to do what I'm trying to do at this time. So I think it's important to realize this. Now, anybody who's going to use this is going to be their own decision, whether they choose this or not. I feel it is important to have the tools and understanding how to use this. Now, today I'm going to show you some intricacies on the ventilator and how we actually have to work on this so we can be much more careful, and there are some interesting aspects that's going to help you be better prepared and also answer some of the questions and how to take care of challenges with the patients in this situation. With that, I am going to take this video here and I'll take it up further. And this is the ventilator that we had seen before, again 840, and I'm going to turn this on. Now, when you turn this on, it's important to keep in mind that we will not have a patient attached to the situation. And if the patient is not attached, only then will the ventilator be able to be set. And if you remember, one of the things that we had set up, the multiple channels and contacts, keep this in mind. You can cap the ones that you're not using. So this is a smart way to do this, is to make sure the ones that are not being used are closed. So we are doing just, I didn't want to do the whole exercise all over again for the 7 ventilators, but I wanted to actually, 7 patients. I am doing this with 2 of those closed, and we are going to do 2 lungs to illustrate some important examples. The part on the inhalation side and the part on the exhalation side. Both of them are there. So now, with the ventilator setup, some concepts to be kept in mind. So I am actually going to set up an IMV mode, and I want you to understand this. There's a reason for it, and I'll explain that to you in a second. So when we do the IMV mode, just to illustrate, I'm putting a rate of 10, and I'm doing a pressure control mode. And the pressure control mode, I'll set that up. So first, we set up a weight for the patient, and the weight of the patient, in this case, I'm just going to go to a maximum for the time being. And we will, at this time, also go to IMV mode and pressure control. And I'm not going to give any pressure support, 0 pressure support. So there is a rate of 10. Tidal volume is not set as at this time because the pressure control mode, and 0 pressure support. And oxygen, again, we are not going to use any oxygen as we try to do this. And PEEP, now keep in mind, and I'll go over this as well, it's worthy to talk about. I'm just setting this up at PEEP of 10, and with that I'm going to accept this. And at this time, the machine is going to say that we are waiting for a patient to connect. Now, as we are setting up for the patient to connect, I will connect this patient over here. And this is another patient, right? And I'll come over here and connect another patient. Now the machine should start to talk. You can come up here. Now, here's the thing. The machine is right now a little confused because the tubes are so long and there are so many patients. So there's a way I can play with the mind of the machine. I will disconnect over here and put my thumb in here, and the machine feels that there's a cough, and right now immediately the machine starts to do its work. So we do turn the alarm off, and now you can see this lung is getting the ventilation, and so is the other lung getting the ventilation. Now the brilliance of the pressure control. First, let me just talk about the patients that we are going to deal with, for the most part, are going to be individuals who are going to have ARDS. This is the disease we're talking about, COVID-19. the patients, when they're in the intensive care unit and they're as critically ill, overwhelming majority of them will have ARDS. So we will need high PEEP. Some of the other critical ventilators or resuscitators do not have the capacity to give PEEP and do not have the capacity to give oxygen. This can give oxygen up to 100% and we need that, and this can give a PEEP up to as much as you may want. It can give a PEEP up to a 30 if need be, or 23 in this, but we can bypass that as well. And that's why it's worthy to use a machine that can actually give a high PEEP, so improve the oxygenation opportunity that we have. Now, back to what we're talking about. The brilliance of the pressure control is that the pressure control will give the volume of air to the patient according to the compliance of their lung. And if it gives it along with the compliance of the patient's lung, we will actually have the opportunity to set up the pressure that we can set up, and then that will be, if there are 5 patients or 7 patients or 2 patients, they will get the volume according to the compliance challenges. If the lung is very stiff, they will get less volume. So we know in advance if they're going to get less volume, their carbon dioxide levels will go up. So they need to be monitored, they need to be addressed, and there's a way to take care of it. And if we actually also have another situation, if we have a patient who is breathing above the set rate that I've kept at 10. So now if this is a patient, this patient is going to breathe at a rate of 10 right now with a machine. But if the patient starts to breathe faster, that is going to actually only impact this patient. And if you look at the other patient right now, this other patient is not being impacted. The other patient is breathing at the same rate as it is supposed to. But the first one that I'm breathing with is breathing at his own pace. That is the brilliance of the IMV mode. The IMV mode is going to work in a way that the patient who is trying to pull breath outside of the 10 breaths that we have set up, they will be on their own. So it would not impact all the other patients. So if you're going to use this mode, use a pressure control with IMV and play with the oxygen that you need for the patients and play with the oxygen that you need for the PEEP that you need for the patients. That is going to be a way to be able to reduce the impact of one patient having on the other. Now, one of the questions somebody said was that, okay, if a patient crashes or God forbid is get a cardiac arrest. Well, what you do is, like every other situation in the intensive care unit, when we do is, we actually have the patient be on a bag. We bag them, but as soon as you disconnect, everybody else is going to be impacted, so you have a stopper. You put the stop here so that none of the other patients, whether they are 7, 5, 8, or 12, or none, you actually have no impact on the rest of the patients by blocking this, and you do the bagging for the patient and take care of them. This is very simple, but you just have to be aware of this. The other issue that we talk about is that if the person is not getting the same amount of volumes, they're not able to blow off the carbon dioxide. If they're not able to blow off the carbon dioxide, their PCO2 goes up. Now, the patients in this particular disease are dying from low oxygen. They're not dying from high PCO2. But if you know that their PCO2 is going to be high, you can actually fix it by permissive hypercapnia that we do all the time with the bicarb drip and so on. But I think that's important. In principle, there is a way to do this. Let me turn the alarm off for a second. This is the low tidal volume because we have less of the other patient there. So with this in mind, I will actually share with you that first of all, you do this in the absence of ideal situation. If you don't have enough resources, if you don't have the capacity and you want to fight the fight to save as many people as you can, you need to have experience and expertise and understand what it would entail, but also be able to save the patients who you can save and help them out, knowing that this is not a perfect situation, but in the imperfect world with the imperfect disease, you have to try to do the different things and you have to have a mechanism to check it and protect the people that you can and then take care of this. I hope this is going to help you understand some of the intricacies and the basics of why and how we can do this. And I'm sure there'll be more questions and I can address them as they come along, but hoping and praying that none of us will ever have to use this, but it's a good thing to have in our back pocket should we have to use this. Thank you again, and then please stay safe.